Hi, I'm Corey McFarland. I'm one of the anesthesia providers here in Sioux Lookout. Today we're going to go over protected code blue apneic oxygenation. There's been a lot of talk around the world in emergency and critical care providers that we should try to expand the lungs as we're doing CPR in a way that doesn't cause viral particles in the air. We don't want to compress a bag still, but there's now a way that we can probably create some PEEP. And if you take a look at our bag, what we have now in the trauma bays, and likely all through the hospital, is our bag valve mask. On the end, there's a PEEP valve that should be in place. Normally there's just a little white cover. So now it's a PEEP valve that it's dialed up to something. So somewhere between 5 and 10. And that's a decent amount to start with of PEEP. Next we have a viral filter and a mask. So that's the simplest form. And now if we we have our oxygen tubing that's normally in place, and you shove flushed from the wall, so 15 to 25 liters into your bag. As the oxygen is flowing through your bag, there's a little red valve here that normally when you're squeezing air in with the bag, the valve opens. You can see on this one, the valve wiggles a little bit. So on the way, as I'm squeezing, air gets let into the lungs, and as passively people are exhaling, the valve closes. So there's always 100% oxygen on this side of that little red valve. Now in apneic oxygenation, we increase the flow so much that this little red valve passively opens anyways. And what we would do is we would hook up our oxygen to one line, crank it all the way up to flush. Just crank it all the way. That's what you normally do in a code anyways. Our bag is going to inflate, and if you look at your little valve, it's moved away from its seat. You can feel a little bit of flow here. Not much, but do my hairs move? No. So there's a little bit of flow automatically. This is the CO2 sampling port. It comes like this. So we can actually make this PEEP valve work a bit better if we open that up, take an extra standard oxygen extension tubing, press it onto that CO2 fitting, and then add a little bit of supplemental oxygen, something between 5 and 10 liters a minute. So now we have a little bit more flow. All of our flow is protected by this viral filter. We can put a face mask on, and here's our patient. And I'll just put the mask on without the bag to start with. So the thing about oxygenating someone passively is they're so relaxed when they're in a coma that their tongue and jaw all collapse their airway. So what we want to do, you're normally taught in CPR to do the CE grip, the C and 3 fingers around the mandible and then bag. Now we want to use 2 people if we're going to use the bag, but we want 2 hands all the time. And we want you to place the heel of your hand on each side of the nose and your thumbs down by their lips so you can control each quadrant of this mask, and you squeeze your fingers towards your thumbs. So it's called a VE. You make the shape of a V, and those 3 fingers are an E. So we're making our V and pulling the jaw up, and it's going to kind of dislocate. You'll feel it sublux in these patients who are comatose, and then that draws the tongue and all the soft tissues out of the way of your esophagus, or sorry, your trachea, and you open your airway, and you'll see in cadaver studies someone has cut a bunch of ribs out of here, and passively the lungs inflate with your mask on here, and you pulling the jaw hard towards yourself, and you have a very good seal with the 4 quadrants of your hand here holding on the face. So that's how we're going to do apneic oxygenation in a protected code.
Yeah, and to add, the role of the non-GPA physician in the code is to do this as well as lead the code.
Great.